Dr. Lubega is an internationally recognized leader in global child health, and he is the director of the Global Hope program at Texas Children's Hospital. He established East Africa's first university-accredited pediatric hematology and oncology fellowships, which trained 40 pioneer specialists. He's practiced all over the world at 15 different academic medical centers across 3 continents, focusing on oncology, epidemiology, and implementation science. In 2024, Lancet Oncology honored him for his impact on pediatric cancer care and public health infrastructure worldwide. Last year, he led a really special team of people who was competing in a competition called 100 and Change. This is a competition that's run by the MacArthur Foundation to give $100 million to an organization that is trying to make an improvement to solve an intractable problem. He had an amazing proposal to drastically reduce mortality in Africa by shifting care for children with sickle cell disease from specialized hospitals to local primary healthcare systems, leveraging the infrastructure that had been built to improve HIV care and malaria programs. His proposal was called A New Day for Children with Sickle Cell Disease, and it really would mean a new day. It aimed to reach 1 million children across 10 countries by 2030. Now, unfortunately, his team did not win. I personally think the MacArthur Foundation made a big mistake, and it wouldn't be the first mistake they made. If you know, you know. But Dr. Lubega, he is not a quitter. He is a very persistent individual. And so all I can say is stay tuned to see what comes from all of his efforts, because I promise you something big is coming. So Dr. Lubega, we present this award to you today. I'm going to give it to you after your talk because it's kind of heavy and I don't want you to have to hold it during your talk, but we present this award to you today with gratitude for all that you do for the world's children to make this world a better and healthier place. Thank you for joining us. Thank you for addressing our young innovators today. Please join me in welcoming Dr. Joseph Lubega.
Thank you, Rebecca. I'm such a strong admirer of Rebecca and RISE 360 and all the work that the graduate students here do and the work you all showcase in this competition. And my job today is actually to synthesize and summarize everything that you've all heard this morning and what it really means for the world. So this is Desire. Desire was a first-year student of psychology at Makerere University in Uganda in 2020 when she was diagnosed with leukemia. And a few weeks ago, I got these pictures from her mother because she graduated with an honors degree in psychology. And part of what she's doing is actually taking care of kids with cancer in Uganda, as you see here on the right. So this is why we do what we do. This is why you are all spending time thinking about innovations for global health. It's, for me, some of the most serious business that we do, and I don't want you to underestimate the impact you're having on the world. And I think the caliber of people you have in this room, the judges, and the effort that RISE 360 puts in organizing this event speaks to the importance of this work. This work is very important because the world we live in looks like this, okay? You know, so much is said about disparities in health and everything in the US, but I want you to remember that disparities are a fundamental part of the modern civilization. In fact, there are greater disparities in the poorest countries in the world than in the US. So this is Mumbai, India. And one thing I want you to recognize is most people live down here, not up there, right? So this is Guatemala, right? Most people in Guatemala live there, right? There are people who literally live on the edge. This is Nairobi, Kenya. Nairobi, Kenya has one of the biggest slums in the world. This is called the Kibera, I think. Kibera slum. And again, it doesn't take much to recognize that there were more people down here than up there. Beautiful golf course there, beautiful buildings, and then the rest crowded in that slum there. One of the things that strikes me as a pediatrician, if you ever walk into any of these slums, they're full of children, right? It's not by mistake that if you look in this picture, all you see is children, and it's true. For every parent, mother, father too, you'll find 6, 7 children. This is South Africa. South Africa is actually the most socioeconomically disparate country in the world, and decent buffer between poverty and wealth, right? So the people, the children that live in these communities deserve care. And a colleague of mine, when we talk about everything we do in global health, every now and then we'll, in a criticizing way, say, hey, Joseph, don't you think we are trying to treat poverty with medical interventions? And I always say, yes, we are trying to treat poverty with medical interventions because this cycle of disease, poverty, and disempowerment, political instability, is well proven. And I'm sure you all heard from the student this morning talking about how blindness results in poverty, how women having to travel kilometers to a health facility causes poverty. We are not able to solve the world's political problems and wars. We may not be able to give money to the people who are poor in this world, but if we can solve the disease piece of it and try to end that cycle, we should do it, right? And the woman I showed you, Desire, to me is an example of that, right? These are people who can transform their communities, their societies, who would otherwise be dead. It was accepted before we started our global work that a child with cancer in Africa died, and now it's not happening anymore. So global health is a thing because of that. And as you know, the field of global health has evolved. Up until the 1980s, 1990s, it was missionary work, right? Physician, church, and generous people pack their briefcases, go to a poor place, give out pills, a bit of money. Until HIV came around, and because it was a disease that was disparately affecting people in poor countries, that at some point became important that pharmaceutical companies provide access to medicine in those communities. The strong advocacy that was coming from both governments and other marginalized groups meant that academia became part of global health in a systematic way to address HIV. That has evolved to where we are now, where global health is really part of academic medicine. I can't think of a top academic medical center in the US that doesn't have strong global health work. 2, the pharmaceuticals have to do it because, especially in the world of precision medicine, if you design a drug that is targeting a gene that affects 1% of the population, you better look for that 1% from over the world. Otherwise, your drug will not have people to get it if you focus it on the US only. And it's a big tool for government diplomacy. People have figured that you achieve way more influence, hopefully positive influence, globally, if you take care of people than building bridges and infrastructure projects. I always remind people, we are being affiliated with Baylor College of Medicine, to tell you the personal impact that global health programs have. if you go to countries like Malawi today, you find kids named Baylor. They don't even know what Baylor means, or they know some people from Baylor College of Medicine came around, helped my child, and that is really, really a personal thing for them. So part of the interventions in global health is research. So I want to, there has been a tendency in the past to think of global health as wishy-washy, nice people, very emotional, who go out to, again, dish out some money, help some people. But I think what you show and what to me where RISE 360 excels is to say that research is and technological innovation is a critical piece of global health, right? And this is where, to me, actually, I was talking to Rebecca earlier, that we need to really bridge the idea of global health being what we do for poor countries to what we do for the world. I always remind people that it's now close to 40 years, 1980s, right? When Bill Clinton declared that having sequenced the human genome, every American is going to know their genome and the diseases they are at risk for. How many people know their genome today and the disease they're at risk for? Almost zero, right? Most people don't. Even at Texas Children's, where we treat children with cancer, it's almost impossible to get a child's genome sequenced. Why? The technology doesn't allow to do it because it's very expensive. So the idea that, somehow in America we are wealthy, we can do whatever we want, is not true. And every now and then when I'm rounding with residents and fellows on the wards and they tell me that, we walk into a room and ask them, hey, do you think that family is really wealthy? What do their parents do? Like, no. We go to the next room. Do you think they're really wealthy? Like, no. So, okay, where is this thing that, somehow here in America we are so wealthy, we can design technologies that are ridiculously expensive and do whatever we want, right? So to me, this is a global trend that we need to take into account everywhere we are, the reality that most people cannot afford the technologies that have been designed, and we need to constantly think about more and more cost-effective way of designing technologies. So there is the end of technological innovations that you all do here that RISE 360 focuses on. What I focus on and what we focus on as Texas Children's, being a clinical-oriented enterprise, is this end of how do we get technologies that are proven to work, the technologies you're all designing, to make sure they are used, that people have access to them, and more importantly, that they work well within health systems, which have to take into account the politics, the culture, the workforce, the expertise of the population. So this is a picture actually my daughter drew because she's asked me, hey, Dad, what do you do? What do you do? And because she thought I was supposed to be taking care of kids at Texas Children's, and every now and then I told her, hey, I'm in Kenya, I'm in Malawi. So after some time explaining, she drew this picture to explain what disparities in child health access means. That what we deal with a lot is, hey, there are lots of beds in this world, there's no shortage of therapies for most things or diagnostics, but getting that child or person across this valley to there is a lot of work that we are all trying to achieve. So what I would like to share with you today in the next few slides is what I would consider not the science of global health, but the art and principles of navigating global health. And this is stuff that has been codified by the CUGH, the Universities for Global Health. So, and it's important as you think about everything you design, and it's something we think about as we do the work we do. One is always taking a holistic view, recognizing that healthcare is always a system thing, and it's almost never that the problem is one thing that you solve and everything comes together. It's always complex, and you always have to take into account that complexity. You have to think about also organizational complexity, consider global, national, and cultural trends. Engaging and motivating local ingenuity, very important. I think one of the most lovely things about RISE 360 is not all about US top academic centers designing for Asia, for Africa. It's to make sure that universities in these places are actually engaged in their own innovations. Collaboration, of course, is key. Capacity building is something I'll talk about later more, because I feel like it's a term that's thrown around a lot and it means different things for different people. Being efficient and avoiding waste, making sure you allocate funds where they're most needed. Adopting evidence-based strategies, very important for us as scientists and for me as a clinician. You'll be surprised at how many times things that you would never do in the US, people all of a sudden think it's okay to do because you're in Africa, right? And you ask, hey, where is the data? Where is the evidence that this works, right? You can't just make it up, right? Equity, like we said, there is more socioeconomic disparities in some of the poorest countries, right? I mean, there are probably more billionaires in Lagos, Nigeria than in Houston. So you make sure that if you are trying to resolve global disparities, you are not helping the most privileged families in Nigeria, and actually you are reaching the poorest communities. Satisfying all stakeholders is very key. And lastly, financial integrity. Very important, especially if you're working with communities and countries where there's a lot of corruption. I know many organizations that have run into trouble thinking, oh, just send money and things happen, and before you know it, you're really in serious financial trouble. So capacity building. I think of capacity building as mentoring, self-reliance development, autonomy development, empowerment, self-sufficiency development. What isn't capacity building is teaching alone, right? So teaching students, they graduate, especially without the mentoring component, doesn't necessarily build systems. I emphasize that, to me, global health capacity building is not charity. It's not charitable work. You have to have a clear strategy and often a business strategy along with it, because that's the only way it will be transformative. That's the only way it can be enduring. It's not financial relief. It's not a franchise, right? So it's not creating multiples, case clinics or Mayo clinics in the Middle East and India. That's not capacity building. It's not building local capacity. It's good business, maybe. And of course, it's not any of those negative things that have happened in the far past. So at Texas Children's, we developed this model for us where we have a very systematic approach to our global programs. It's one, identify a need together with a local community, typically ministries of health or local leading academic medical universities. Build a model for care in that area, be it newborn care or childhood cancer. Then as soon as we put a lot of resource in building that model, but in building it, make sure that it is scalable, meaning it can be expanded nationally or even regionally, and can be sustained. And always emphasize, to me, scaling and sustaining are two sides of the same coin, right? Scaling is expansion geographically, sustaining is expansion in time for a long time. And normally it's the same factors that mean that. So again, a lot of our work starts with teaching and mentoring. And a lot of the programs we support are university-based, medical school. We want the people to train to be certified, to be recognized, world-class training, no wishy-washy, training, so that they get promoted in their system, they are recognized as leaders. Then when you train those people, make sure they have the tools so that they can demonstrate success. So that builds the model. But once we do that, a lot of work goes into engaging communities, engaging governments, engaging global agencies. So there is a framework around that stuff, make it stick, and then we can pull out. And you must always plan to pull out. So let me tell you about how this plays out in two examples, for childhood cancer and for sickle cell disease. So childhood cancer. So we've done a lot of work training pediatric oncologists. We focus on training teams. So we don't only train the doctors, but the nurses, the pharmacists, and everyone involved. We stimulate these systems with drug supplies, chemotherapy. We built labs for cancer diagnosis. This shows all the pediatric oncologists who trained so far in Africa, mostly in Tanzania, Uganda, Malawi, and Kenya. All these doctors in most of these countries are the very first in their countries. We've trained up to 200 pediatric cancer nurses. And across them now, they take care of around 2,005 children, 500 children every year, and about 10,000 children with sickle cell disease in their tertiary centers. So one of the impacts I would like to show you is this. This is the normal distribution of childhood cancers in the US. A third tends to be leukemia, brain tumors are caught, and then lymphoma and a few others. When we started this work in Malawi, 3/4 of children with cancer were called lymphoma. So the only way I can interpret that is it was a wrong diagnosis. And as you can imagine with cancer, if you have a wrong diagnosis, you cannot cure it, right? So no surprise that pretty much all these kids were dying. Fast forward, you start to seeing a plethora of all different cancers, right? If you go to Uganda, where they are more advanced and we started this work earlier, it's starting to look more and more like the USA. And I was talking to Claire here, one of the judges earlier today, that when you look at the cancers that they are not detecting, they are cancers that probably require some technological innovation. So brain tumors. You can't diagnose a brain tumor without a CT scan, without an MRI scan. And these systems really struggle with such high capital equipment. So we've really improved the outcomes of these children. Yes, they are still suboptimal compared to the US, but it's thinking that within 7 years, we moved from a place where pretty much every child with cancer died to a place where about half of the children survive is really a lot of improvement. And to me, again, the most important thing, this is not being done by Texas children's doctors. It's done by the local doctors, the local teams. So I'll give you an example of scaling. So sickle cell disease. Sickle cell disease was the first human disease to be determined to be caused by a genetic mutation. It was discovered in 1910 at Rush Medical College in Chicago. And it's the most common genetic disease in the world as well. Between 1910 and about 1980s, every child with sickle cell disease in the US pretty much died by the age of 10. Between 1980 and early 2000s, 3 things changed that completely. One was newborn screening. Everyone in the US right here, right now, you don't even have to be African American. You have to get a sickle cell test at birth. 2 is vaccination, especially vaccination including pneumonia. 3 is penicillin. It's really old, beautiful penicillin that costs almost pennies. So they take a pill of that every day for their first 5 years of life. And a drug called hydroxyurea that ramps up their hemoglobin, fetal hemoglobin, which is resistant to sickling. And those interventions, as simple as they are responsible for 80% of the improvement in outcomes of people with sickle cell disease in the US, to the point that most people now in the US live to their 50s. And the only reason we are talking about 50s is because the treatment started in 1980s and so on. So we think that as time passes, the survival is going to be more and more. So the problem is 85% of the world burden of sickle cell disease is in Africa. And as simple as these interventions are, they are not widely available. And I can't tell you exactly why. I want to attribute it to the fact that the period when, say, in the US, sickle cell care was becoming available, Africa was focused on one thing, HIV. This was when HIV was peaking and all hands were on deck for HIV control. So with our work, when we trained the first pediatric hematologists in Africa, we realized they could do this. And they said, hey, we are doing this. The kids we take care of in the tertiary hospitals are doing very well. But the therapies we're giving them are really simple. They don't require a pediatric hematologist, not even a pediatrician to do. A nurse in a rural community can do it. So we came up with a plan to really scale up sickle cell care access with a goal of screening using point-of-care tests, preventing infections using the same interventions I mentioned that I've worked in the US. And of course, in Africa, you add malaria prevention, which is part of the baseline system. Again, all this stuff costs really sense. So I used a tactic of embarrassing the Africa Union by pointing it out to them that the continent that most affected by sickle cell disease doesn't have a public health policy on sickle cell. And they having also said that from HIV, they've learned that Africa should take care of its problems and not wait for USA or European Union to tell them what to do. This is their chance to show that they're serious. And they took on the challenge. And they've committed to this strategy of addressing sickle cell disease by mobilizing everyone that they need to mobilize within and outside Africa, training primary healthcare workers, and we're talking about 1-2-day courses of training someone to perform a rapid test, prescribe penicillin, give vaccines, which most of these people already give, making sure there's a pathway to access these products. Believe it or not, even though drugs like penicillin are very cheap, actually they're becoming less and less available because of reducing market demand in developed countries. And then making sure there is surveillance and integration of data for sickle cell surveillance in the existing data systems. So this strategy is now recognized as an Africa Union strategy. And in 2 weeks, Africa Union actually will be meeting in Kampala, Uganda, to announce that this is the way to go and every country has to show what they're doing in moving this forward. The work has already started. These are just examples of the work that's going on in Uganda. Again, you're talking about rural communities. In this picture, for example, this gentleman here, Philip, is one of the pediatric hematologists we trained. So these hematologists go to the rural areas one day, train the health workers, and then the health workers start screening kids. They've formed a national task force. They're tracking their data. And again, for me, what's most important is all this is now done by the local team, driven by their own motivation and led by their ministries of health. When this project started in Uganda, in one of the districts where it started, around 80 kids were getting any testing for sickle cell disease every month. Now it's consistently, as you can see up there, about 1,000 children being screened every month, and already expanded to 3 other regions of the country. The linkage into care is up to 99%. This is something I'm very proud of, and this is where I get back to what I was saying earlier. When we talk about global strategies, to me, they apply to the whole world. Believe it or not, this is way, way higher than the chances of a child with sickle cell disease in the US being linked into care. Okay, way higher. And actually, when you look at actually how many kids in this project, and I must put a caveat, it's still smaller scale, are on hydroxyurea consistently, it's way higher than in the US, right? So this is all to say, and I'll tell you why I think this is the case. So part of the problem with sickle cell disease in the US, it's considered a specialist disease. So if you're in Houston, a primary care pediatrician who encounters a child with sickle cell disease, the first thing they say is refer to Texas Children's Hospital. Now, that can work if you're in Houston. What happens to the child with sickle cell disease in rural Texas, right? So we have a lot to learn from our global work. Yes, I spoke with about access to hydroxyurea. So this is my last slide, and to me, the most important thing. And I think I can talk about this. I was just chatting with Rebecca about Nest 360. And I was asking her about how it's doing. And I don't know if you know about Nest 360, but I think it was Rice 360's baby to take care of newborn babies in Africa. And she mentioned to me there is a plan to pass it on. And to me, that's very, very important. You haven't succeeded in global work until you can let go. Because if you don't let go, you create a dependence. Not only dependence, but you are reproducing the reasons these countries are in the state they are in, where for many years they were disempowered. And here we are in 2020. We have to sit in Houston and try and fix their problems, right? So the key is every time you do a global project, think about how will I let go so that the local leaders can run with it. Thank you.
Thank you so much. And on behalf of Rice 360, we're so delighted to present you with this award. Thank you. I think we're going to get a photo.
I can't tell you how much I admire Rice 360, and this really means a lot to me. Thank you.
When Rebecca introduced you, she mentioned existing HIV infrastructure as the model for some of this training. Can you talk about how that inspired and just how that was adapted for sickle cell disease?
Yeah, there are two components of that. One, and actually this is something that struck me as I was listening to the presentation this morning, that many of the technologies that students talk about, to me, they apply to so many areas, and that's what makes these systems sustainable. I went to Uganda to take care of kids with cancer, and within a week, I didn't know what I was doing because you couldn't get a diagnosis of leukemia, which in this day and age requires flow cytometry. And one day, week 2, I'm roaming around the main campus in Kampala. I walk into the HIV lab, immunology lab, and they have a flow cytometer I've even never seen in the US. And believe it or not, all it took was an air ticket for a flow cytometry technician from Houston to teach the technician in Uganda how to do leukemia flow cytometry. And within week 3, we had world-class leukemia diagnosis, and has never stopped, never been interrupted to date. And the beautiful thing, we don't even pay for the machine. We don't pay for its maintenance. All we pay for are the reagents for leukemia diagnosis. So that's an example building on HIV. Sickle cell disease. When you think about what the model for HIV care, right, what is it they do? It's exactly the same as what children with sickle cell disease need. It's screen them using point-of-care tests as soon as they're born. For kids with HIV, typically they are screened within weeks. For sickle cell disease, you have up to 6 months to screen them. 2, you need to put them on oral medicines for life that require tracking, clinical appointments, and so on and so forth. 3, you need to challenge social stigma associated with HIV, associated with sickle cell, genetic disease, inherited. So really similar problems. So what we did is actually we asked NGOs that do HIV work to start all the sickle cell stuff we're doing. And we told them, we'll get you the drugs, we'll get you the screening kits, but you know how to move the drugs. You know how to supervise rural health workers. You know how to collect data. please help us. And they're doing it. So we didn't have to create a new model for that.
You talked a lot about social stigma, especially with conditions like HIV. Social stigma can kind of be something sort of nebulous in our day-to-day lives. How specifically can we as young professionals work towards, at the same time we're working towards global health technologies, simultaneously work towards reducing social stigma?
Whew, that's a tough one.
Sorry.
I'll tell you my perspective on it. Because a lot is said about this stuff that's, like you said, it can be very nebulous. My observation is wherever you have a disease that affects a big chunk of a population, that causes a lot of suffering, and people don't have a solution, they'll come up with an explanation. And that explanation usually is in terms of spiritual or social explanations. Oh, they must have done something wrong. They must be cursed. This must be something about it. So that's the stigma. So as far as I'm concerned, the best way to challenge stigma is not to talk people out of it or do some, distribute leaflets. Is make them better, solve the problem. That's what happened to HIV. Okay, I was born in Uganda. I was in medical school when HIV was raging in the 1990s, and stigma everywhere. Today, people proudly tell you they have, not proudly, but people will tell you they have HIV. Why? Because it's become like diabetes, hypertension. They know they will take pills and get better. We are starting to see it with sickle cell disease in a very short time, right? When we started this work, parents would use all sorts of, what do you call it? When you use a word that, euphemisms, to mean their child has sickle cell disease. Now, they walk into clinics and say, hey, my child has sickle cell disease, our family has sickle cell disease, and we're on this drug, and we are talking to other people about it. So I think solving the medical problem is the crux of the matter, and to me, a lot of the spiritual, social, and all sorts of challenges is peripheral to the issue.